Hi, it's Callum. In this video, we're going to talk about immunohistochemistry. Immunohistochemistry, or IHC, is the main adjunct test that we use in tissues in diagnosis based on tissue sections. You can also use immunocytochemistry, or ICC, based on cytology preparations. But I've not got examples of them here, but it's exactly the same principle. I'm going to talk about IHC in this video. So immunohistochemistry is the main adjunct test that we use to supplement H&E sections for H&E diagnosis. We also use histochemistry without immuno, also known as special stains, in a variety of settings. But IHC is what I'm going to talk about in this video, and that forms the majority of the adjunct tests that we use, and they're used very commonly in routine diagnostic practices. So IHC essentially to summarize it, it is an in situ test. So we can still see the tissue architecture, as you can see here. So it's very useful for us as pathologists who are morphologists, who are used to looking at tissue architecture. And it can be, and therefore you can compare it to the H&E and use the H&Es to decide on the best section to use, etc. And that has an added benefit. You can look at exactly what tissue type, exactly what cell you're looking at, because IHC might stain the different cell types differently, but you might only be concerned with the cancer, how it's staining the cancerous cells, for example, and you not really be interested in how it's staining the other cells in the background. And when you contrast to some of your other antibody-based techniques, which have the ground and bound approach, where you just get an overall level of antibody binding, IHC has the big advantage that you can still see the morphology and see exactly what cells are staining and also how they're staining, where they're staining within the cell. So immunohistochemistry has multiple uses. It's all based on the same idea that we're looking for antibody binding to a specific protein. We use specific antibodies, of which we've got a vast array to choose from, which each will stain a specific protein. And it's got multiple uses. So we might use it in the context of malignancy of unknown origin, where we've got a malignancy that's turned up, it's been biopsied, we know it's a metastasis, but we don't know where it came from. And we can look at that and see on H&E, where does it look like it came from? Does it still resemble some sort of tissue? And we might narrow down our IHC panel based on that. But often we'll then progress to use IHC to stain for different proteins, because different proteins will be expressed in different tissue types. For example, a commonly used one is CDX2, which is expressed in the GI tract. So if we use immunohistochemistry for an antibody that binds to the protein CDX2, and it positively expresses that in this tumor, then we can be reasonably confident that this tumor is of GI tract origin. And we've got a vast array of IHC options at our disposal. So that's malignancy of unknown origin. Another use we might use is subtyping malignancy. So we might know, for example, this is a testis tumor. We're in the testis. This is a testis tumor. But subtyping those based on morphology is sometimes a bit tricky. And we can use different immunohistochemistry, which our panel of immunohistochemistry of different antibodies. And based on the staining pattern within that panel, we can narrow down the diagnosis to a specific subtype of testicular carcinoma or testicular cancer. Sometimes IHC is so effective that actually the diagnosis almost relies on it. I mean, we always use morphology, but sometimes IHC is really useful, and the diagnosis almost rests on the IHC staining. For example, on diagnostic biopsies in lung cancer, often deciding between adenocarcinoma and squamous cell carcinoma, it will all rest upon the IHC staining pattern. It's so useful and reliable in that circumstance. Also in lobular carcinoma of the breast, the loss of E-cadherin is almost synonymous with lobular carcinoma in the breast, although again we still obviously use morphology is obviously incredibly important as well. P53 mutation is almost synonymous with high-grade serous carcinoma of the ovary, so it's very useful to use immunohistochemistry against P53 in that situation. And another situation that's commonly used is deciding whether something that you've already decided whether it's malignant, but whether it's in situ malignancy or whether it's invasive malignancy, and that based on invading through the, for example, the myoepithelial layer in breast. So what you do is you stain using immunohistochemistry against the myoepithelial layer, and if the stain highlights the myoepithelial layer around the carcinoma, you know that's DCIS or carcinoma in situ. Whereas if there's no myoepithelial layer anymore, then that's become invasive. So staining the myoepithelial layer or the basal layer in breast or prostate and in some other situations is very useful in deciding whether something is malignant. And the last main category is you can sometimes use immunohistochemistry as a surrogate for other more expensive tests. So for example, or a screening before you do more expensive tests. So for example, in Lynch syndrome, which we look for loss of the mismatched repair proteins, we can use immunohistochemistry to look for loss of the mismatched repair proteins. And if that is confirmed on the screening, then it can go on to further testing to confirm that. Or indeed, P53 mutation, as I mentioned in high-grade serous carcinoma, is a surrogate for a more expensive test. But immunohistochemistry is so good that we can just use P53 mutation. Okay, so immunohistochemistry will all look approximately like this. So we use a hematoxylin counterstain. So if we look at an unstained part of the section down here, maybe we can see. Yeah, we can see all these little blue nuclei everywhere. This is not a tumor. The tumor is coming up in brown, but you can see the hematoxylin staining the nuclei. We don't use eosin, just use hematoxylin to stain the nuclei, so we can see the outlines of or see where the cells are. And you can see the blue nuclei within the tumor, within the staining bit, and also out here within the non-staining bit. And it helps you can see architecture that way. Not as good as as an H&E for looking at morphology, but it helps you see the tissue architecture. So we've got a hematoxylin counterstain, and then the brown stuff is the positively staining immunohistochemistry product. So this is a stain against CD56, which is a particular stain that we often use in neuroendocrine tumors, which is positive in neuroendocrine tumors. So with immunohistochemistry, it's a multi-step technique, and you've got proteins that are expressed. Use an antibody against that protein, and it binds to that protein. That's the primary antibody. Then you use a secondary antibody, another antibody that binds to the first antibody, to the Fc component of the first antibody. And that secondary antibody has horseradish peroxidase on it, which catalyzes a Dab reaction, which produces brown pigment. So it's a multi-step process. And usually it's brown pigment. It can be red in other circumstances. Sometimes we like to use red pigment. And it will all look like this. So these are positively staining because you can see the brown pigment. And these cells here are negatively staining. So there's no brown pigment there. And this is a good example of membranous staining. So not only does it matter if it's staining, it matters where it's staining. So this is CD56, which is something we expect to see on the cell membrane. And this is having membranous, this has got membranous positive staining. So you can see around the cell membrane, you can see this highlights nicely in a way you can't really see in H&E, the outlines of the cells, the outlines of the cell cytoplasm on the cell membrane. So this is positively staining all of these cells. And we can grade the positivity in different ways and in different parts of the body. Sometimes it's a bit vaguer, but in other situations, for example, in the breast where we have all red scoring, we've got a very clearly defined grading system based on how well it's staining. But this is strong membranous staining here. This is really clear membranous staining. So that's an example of membranous staining. Another type of staining we might see is cytoplasmic staining. So this is AE13, which is a cytokeratin. And this, as well as you will see membranous staining in a cytokeratin, but you'll also see cytoplasmic staining. So not only is this highlighting the outlines of the cells, it's also staining within the cell cytoplasm itself. These are positively staining cells. They're all brown. You can see the hematoxylin stained, counterstained nuclei. And it's also staining within the cytoplasm and the membrane as well. And these are cytokeratins. They're quite good stains. They stain really clearly, and you can see the cells of the lamina propria, which are not. So these are cytokeratins are good for highlighting epithelial cells, and these non-epithelial cells are nicely negative, but the epithelial cells are all nicely positive. So that's cytoplasmic staining. And the final type of stain is nuclear staining. So this is immunohistochemistry against PMS2, which is one of the mismatch repair proteins. And this is colon cancer looking for this is used as a screen for Lynch syndrome. So here's normal. Normally, within these nuclei, now you can see the H&E counter stain, the hematoxylin counter stain is picking out the nuclei, but then we're obviously staining on top of them. So you can't see the counter stain often so well in positive cells in a nuclear stain. But these are highlighting these cells, the nuclei of the cells nicely in the normal situation. So that's got normal cells with normal mismatch repair protein expression. And this is the cancer. This has also got mismatch repair protein. So mismatch repair protein is intact in this situation. Don't worry too much about that. The point of this video is just to show you the three different types of staining. We've covered cytoplasmic, membranous, and this is nuclear staining. This is highlighting the nuclei quite nicely in brown. This is maybe moderate staining, because strong staining is very clear and very dark. And this is maybe moderate staining, but it's definitely positive, definitely nuclear, and that's what we'd expect to see. Okay, so that's a quick run through, quick introduction to immunohistochemistry. So hopefully in this series of videos we've covered the basics of looking at H&E with a real beginner's guide to looking at H&E sections. We've covered the majority of the tissue sections and the tissue types that you will see in routine practice. There were some that were missing that I would have liked to have covered, but unfortunately I'm a bit time limited, and also I didn't have access to some tissues that I would have liked to have shown. But you'll come across them in practice, and I think having looked at these videos, spent some time looking at these videos, hopefully it'll give you a bit of a grounding, which you can build upon when you go to see live sections, and also your teaching cases as well. And finally, we've finished off by a quick introduction to immunohistochemistry. Immunocytochemistry, as I said, uses exactly the same principles, but it would be based on cytology specimens. And histochemistry would again look, it's another in situ test where we use special stains, but each of those stain differently, and I think it's probably best to leave that. You'll come across them in your practice. So hopefully you've, if not enjoyed that, at least got something from it. And best of luck with your training. I hope you enjoy it. Maybe you'll see you around sometime. And my customary finishing phrase of "speak to you soon" doesn't seem appropriate here, so I'll just finish by saying good luck. All right, take care. Bye-bye now.